Welcome to the Advancing Prevention in Healthcare Settings, Data Quality and Interventions mini symposia session. I'm Megan Ranney. I'm an emergency physician and Associate Dean of the School of Public Health at Brown University. I'm also one of the FACS Consortium co-investigators and faculty. It's just, as I know folks have been saying throughout the day, it's an absolute honor to have you all here for the third annual symposium. Wishing it could have been in person, but thrilled to connect with friends and colleagues, new and old, virtually. As a reminder, this session is being recorded. Only the presenters and moderators are visible, and chat is disabled. So please use that Q&A feature for all questions. A live transcript is available for the session. If you prefer to hide the captions, click on the up arrow next to the transcript button and click hide transcript, or read it closed captioned if you prefer. So I'm just thrilled to welcome you to this because as a practicing emergency physician and violence prevention researcher, I'm committed to leveraging the potential and opportunities within healthcare settings to advance the prevention of firearm injuries. This afternoon session matters just so much. You know, this is what drove so many of us to become active in the field of firearm injury prevention, were the injuries and the very few prevention success stories that many of us had, and the desire to create a science around this healthcare setting-based injury prevention for firearms, just as we have a science around healthcare-based prevention of many other types of injuries. The abstracts that we'll be discussing today serve that goal of advancing the science and hopefully will engender some great discussion after the presentations. So without further ado, let me have you join me in providing a warm welcome to our presenters. First is Dr. Bindi Naik Mathuria, an Associate Professor of Surgery and Pediatrics at Baylor College of Medicine. She'll be sharing results from a project examining the accuracy of data on non-fatal shootings. Then Dr. Sophia Chowdhury, a pediatric emergency physician at Emory, will talk about the feasibility and acceptability of firearm safety education and safe storage devices in the pediatric ED. Third, Dr. Jennifer Deneen, an associate professor in residence in the Department of Public Policy at the University of Connecticut, will talk about the barriers and facilitators that healthcare providers perceive when delivering safe storage anticipatory guidance. Finally, Dr. Eric Siegel, professor of pediatrics and adolescent medicine at University of Colorado, will present on the extent to which training pediatric healthcare providers on firearm safety counseling improves their knowledge and confidence to deliver this counseling. After the presentations, we will have a Q&A session. So again, please submit your questions using the Q&A feature located in your bottom menu and send in your questions as the presentations go along if possible. We'll answer as many as time allows. So I already have us a minute behind, so I'll stop talking and let us get started with the first presentation. Dr. Naik Mathuria.
Good afternoon. Today I'm going to be talking to you about inaccuracies in trauma registry data regarding shooting intent for pediatric firearm injuries. Next slide, please. This work is funded by a CDC grant. Next slide. Pediatric firearm injuries are a leading cause of morbidity and death. Accurate data on the scope of the problem is important to guide injury prevention efforts and policy, as everyone knows here. At trauma centers, injuries are coded by the ICD-10 E codes, external cause of injury codes. Here you can see them on the right. They're divided into accidental, intentional self-harm, and assault. And then there's some others such as legal intervention and others. But these are primarily the three categories. So if you look at accidental handgun discharge, malfunction, discharge of specific firearm, these are interchangeable mostly with the unintentional injuries that we all talk about. Intentional self-harm is suicide or suicide attempt. And then assault by handgun, it tells you exactly what types of guns are used for the assault. But notably, there's no E code for bystander or stray bullet shooting. Next slide, please. The National Trauma Data Bank, often called the NTDB, includes institutional trauma registry data from over 900 trauma centers. It's the largest repository, and it facilitates research, especially for non-fatal firearm injuries. As we just heard in the last panel, there is a need for reporting of non-fatal firearm injuries, and the NTDB is a nice way to do that. However, the The accuracy of data for pediatric firearm injuries has not been previously studied using this registry. For example, this is a recent publication from that database, and it again groups these into assault, unintentional, and self-inflicted. Notice there's no bystander shootings included. Next slide, please. When you look at unintentional or accidental firearm deaths, it has been shown that there is some inaccuracies when you look at the death data. For example, the CDC Wonder uses the National Vital Statistics System, and Whiskers uses National Violent Death Reporting Systems. When these were carefully reviewed, the unintentional or accidental deaths, shooting deaths, were both under and overreported, interestingly. And that's because there's issues with, for example, manner of death is often listed as a homicide, even if it was an unintentional intent. If another child shoots another child, it's called a homicide. It does not go in the unintentional category. And the ones that are listed as accident is only when a child shoots him or herself. So these are just some of the problems with this categorization system. Next slide, please. However, it hasn't previously been shown that there's inaccuracies in shooting intent in trauma registry or medical charts that all then go to the National Trauma Data Bank for both fatal or non-fatal pediatric shootings. We were also interested in determining how exactly bystander shootings are coded. Are they coded as assaults, or are they coded as accidentals? Because really they are kind of accidental. It's just the wrong time in the wrong place. And we wanted to test the hypothesis that the accidental or unintentional category is the most inaccurate. Next slide, please. So we cured the institutional registry for pediatric patients at one pediatric level 1 trauma center. This is early data from our grant. We, at the end, will have many more, but this is just data from one center. And we compared the retrospective, what was listed in the registry and had eventually gone to the National Trauma Data Bank with a manual chart review of the medical records. This is reviewed by 2 or 3 abstractors, and any opinions that differed were then reviewed in a group meeting. The categories for shooting intent in the registry are, as we talked about already: assault, accidental, intentional self-harm, and then unclear or other. In chart review, we specified intentional discharges intended for a victim or an affiliated group. So for example, a drive-by shooting, that's intentional. Or shooting into a house, trying to hurt someone in the house is intentional, even if the child was caught in the line of fire. The negligent discharge is the unintentional or accidental category. We decided to call it negligent discharge to clarify. Intentional self-harm, suicide or suicide attempt. And then bystander, when it was not intended for the victim or the affiliated group. So if they just happen to be by, for example, standing in a park or standing at a party, and then they were just struck by a bullet that was not intended for them. And then unclear other. It's not always clear what the shooting intent is, as you all know, but often the social workers at these children's hospitals get a very good history. And so it's sometimes your best guess. Next slide, please. So these are our results. There was 89 patients. Most of them were male. Most of them were Black, as you can imagine. 32% were Hispanic, 5% white. The other races were very, very rarely injured. The most commonly injured age group is a 15 to 17 year age group. And then you can see 37% 6 to 14 years and 20% in the 0 to 5 years. So even little children are getting shot. They may not be dying and they may not be showing up in the national mortality databases, but they definitely are getting shot. Next slide, please. So when we compared the trauma registry shooting intent to the hospital chart review shooting intent, you can see that the intentional self-harm category was the same. But the assault and accidental categories in both the trauma registry were both overestimated. There was no bystander category in the trauma registry, and then there were some that were unclear, as is expected. Next slide, please. So if you look at the bystander, 79% of these were coded as assault, 16% were coded as accidental, 5% unclear. The boxes represent the true positives. So the negligent discharge, 92% were coded as accidental. Intentional, 81% were coded as assault, and unclear, 22% were coded as unclear. Next slide, please. So when you look at the sensitivity, specificity, positive predictive value, and negative predictive value, you can see that in the assault category, the accuracy was about 73%. In the accidental category, the accuracy was a little bit better, 86.5%. Next slide, please. So in conclusion, data obtained from the National Trauma Data Bank can be inaccurate regarding shooting intent for pediatric victims of firearm violence. Both assaults and accidental or unintentional shootings are overestimated. Assaults are least accurately coded because most bystander shootings are coded as assaults. And as we know, there's different social determinants for bystander shootings versus for intentional assaults or homicides. Validation of these findings at other pediatric trauma centers is necessary, but we propose that adding a bystander shooting intent E-code should be considered for more accurate data reporting. Thank you.
Thank you for that terrific presentation. Nice work. Next is Dr. Chowdhury.
Thank you. Good afternoon. First, I'd like to thank all of my co-authors for their continued commitment and dedication for this project, and also my senior mentors, Dr. Anna Weiss and Joel Fine, for their thoughtful approach in helping us design this project and their continued mentorship. Next slide. We have nothing to disclose. Next slide. Playing with a gun is the most common circumstance for pediatric unintentional firearm injury for both older and younger children, with a majority of these occurring at home. Guns that are typically involved in pediatric firearm-related suicide are most often found in the home of the victim, family member, and close friend. Prior research in community settings and in pediatric practices has shown that the coupling of firearm safety counseling along with the distribution of safe storage devices increases the reports of safe storage at home. Emergency departments currently provide resources for families related to social and safety concerns. However, there is limited data on the best approach for providing firearm safety counseling in the pediatric ED. Next slide. Our objectives were to assess the feasibility and caregiver acceptability of providing firearm safety education and free safe storage devices in the ED, and to evaluate caregiver practice changes after receiving these interventions. Next slide. For this pre-post intervention study, we enrolled English-speaking participants from a tertiary single pediatric ED. Participants were enrolled if they were a parent or a legal guardian of a patient that was less than 18 years of age. For this initial visit, they completed a self-administered electronic survey, and they received video-based firearm safety education. The surveys gathered information related to demographics, firearm safety knowledge, and current practices. If the participant said yes to either having a gun in the home or a gun being brought in the home by someone else at any point during the week, they were offered a cable lock and watched an instructional video. Next slide. All participants were sent a follow-up survey at 2 weeks, and those with gun exposure were sent an additional survey at 2 months and 6 months. All participants that completed a survey received gift cards. Statistical analysis included descriptive tests and chi-square and a McNamar test for assessing practice changes. This study was powered with an alpha of 0.05 and a beta of 0.8 to demonstrate an effect size of 15% for storing guns locked. Next slide. Our results. 307 caregivers were enrolled that had also completed the baseline survey. A majority were female between the ages of 25 to 44 and cared for 2 or more children at home. Among that group, 43 of those caregivers, or 14%, had gun exposure, and 39 of them had a gun within their own home. They had similar demographics to the larger group, except that there was a higher percentage that cared for 2 or more children at home. Next slide. Of the participants with a gun at a home, with a gun within their home, the most common purpose for the gun was either safety or protection. A majority had 1 gun at home. However, 13% had 3 or more guns within their home. And handguns were their most common type of firearm. The most common storage location was within the living spaces. Next slide. For handgun safe storage practices, more than 80% reported using a safe storage device. However, 14% that did not always lock their gun, and 17% kept their gun loaded, and 40% did not keep their ammunition stored separately. The lockbox was the most common type of safe storage device that was reported. 47 of our participants received at least 1 cable lock, 20 with gun exposure and 27 without. If participants asked for more than 1 lock, they were allowed to take more than 1, and a total of 69 cable locks were distributed. Next slide. For follow-up survey completion, 78% of our participants completed the 2-week survey, and for those with gun exposure, 53 and 44% completed the 2- and 6-month survey. Next slide. One of our acceptability measures, one of our feasibility measures was that we were hoping to see that more than 75% would at least find this ED intervention acceptable. And as you can see, when asked at the 2-week mark, 75% or more of our participants found that this information was useful, that the ED was an appropriate place to discuss gun safety, and that the education they received would help them ask about guns when their child or teen would visit other homes. Next slide. At the time of our intervention, 36% of our participants had already asked about guns in the home prior to their teen or child visiting other homes. After the ED intervention, 68% of our parents that had the opportunity to ask had asked by the 2-week mark. Given the circumstances with COVID-19 and social distancing, we added an additional question during our study, which basically asked parents and caregivers if they would ask about firearms in the home when social distancing was over. And as you can see here, a majority said that they would at each of the follow-up time points. Next slide. More than 75% of our participants shared the gun safety information that they had received with family members, friends, and community members after the initial ED intervention. By the end of our study, a total of 6 participants had removed guns from their home. Next slide. Among those that had guns in their home, a majority continued to demonstrate safe storage practices at each of the follow-up time points in terms of locking their guns in a particular type of safe storage device. For those that own guns and actually took a cable lock from us and had completed a follow-up survey, the majority were still using the device as time went on and had stated that they wanted to keep the family members and those that they cared about safe as a purpose of wanting to use the lock. Next slide. In terms of our limitations, we had a small sample size. This was a single pediatric ED in a large mid-Atlantic city, potentially may not be generalizable to other populations. Some of our participants were lost to follow-up. Additionally, some of our participants may not have been forthcoming on gun access and whether or not they were practicing safe storage. Next slide. In conclusion, provision of firearm safety education and cable locks in the pediatric ED is feasible, acceptable, and the education and device distribution led to changes in actual and intended firearm safety practices as listed here. Next slide. We currently have 2 ongoing quality improvement and implementation studies for firearm safety counseling and the distribution of safe storage devices. One is in our pediatric ED involving our social workers and the behavioral health population with plans for universal distribution. And then the second is within our primary care population, particularly in families with young children. Thank you.
Thank you so much. And I'll remind folks to put questions into the Q&A. Next up is Dr. Deneen.
Thank you. I'm here today to talk about facilitators and barriers that physicians might face around anticipatory guidance on safe firearm storage. You can see our research team here, and I should mention that the project is funded by the University of Connecticut's Institute for Health Policy and Intervention. Next, please. Our project set out for 3 aims. The first is to understand what general practitioners see as barriers and facilitators to patient conversations concerning firearm safe storage. Second was to understand if and how behavioral, normative, or control beliefs towards safe storage might vary among GPs in states with differing legal contexts. And third, this is formative data collected as part of a pilot study, sort of testing the waters before pursuing future work. And so I will mention that as a pilot study, it's a small sample, and the research team fully acknowledges the limitations that go with that. Next, please. So we conducted 18 qualitative interviews with general practice physicians. These are physicians that spend 80% or more of their time on direct patient care. Physicians were recruited from the Schlesinger Group physician panel, and respondents were stratified by state safe storage setting. Interviews were about an hour or so via Zoom. You can see on the right-hand slide that there's some variance in terms of demographics, gender, race, and geography, urbanicity, and region of the country. Interviews took place this past summer between May and July of 2021. Next, please. We recorded and transcribed interviews. We had independent manual coding of the transcripts by 2 research team members, and then they were reviewed. The codes were reviewed by all team members. Coding was iterative, and codes were refined, and actually we continued to do so. Next, please. I'm going to move from what we did to what we found, and I want to give a bit of a roadmap before we do that. So I'm going to first talk about anticipatory guidance conversations in general, how much time is spent, what gets covered, about physician decision-making process in determining what they cover, the role of comfort in conversations regarding firearms, and then potential conversation starters or facilitators. Next, please. You can see this word cloud shows the variety of topics that physicians volunteered. They include in their anticipatory guidance conversations. These are all topics that got more than one mention, and the size of the word is indicative of its frequency. Vaccine definitely topped the list, COVID specifically in some cases, but vaccine more generally, cancer screenings, mostly women's cancers and colon cancer, general wellness, sexual health, smoking. You can see in the middle, gun safety came up rarely, twice actually. Next, please. When we asked about the time spent on anticipatory guidance, not having enough time or having more to cover than time allowed came up fairly frequently, very explicitly by about a third of the participants, but then sort of peppered through the conversations. And we heard things like, we have verbatim quotes on the slides and the boxes. So doctor said things like, we need 36 hours a day, and I don't think any provider will tell you they have the time that they need. Next, please. Physicians mentioned screening tools as a strategy for deciding what topics they cover in the anticipatory guidance part of the conversation. Almost half say they depend on the EMR to determine what they cover, and another quarter stated that they don't cover certain things, including firearm safety, because it's not part of the EMR. So they might say things like, my resource is the US Preventative Service Task Force, or a lot of docs aren't doing anticipatory guidance as they should be, citing using basic or the cheapest EMR as the screening mechanism. Next, please. Physicians are also screening using their own perceptions of who's at risk for firearm injury to decide whether or not to discuss safety with their patients. And so we heard things like, it's completely different depending on the patient, or I have yet to have any patients report problems with someone stealing their gun or having a bad outcome in that. I know it's a nationwide problem, but it really hasn't been one in my patient base. Next, please. And if we can move next, please. Thank you. Physicians are also screening on patient receptivity. And they're saying things like, I might have a preconceived notion that I shouldn't bother bringing it up because I know this patient, or the patient's mindset more than anything, the patient's readiness to hear what you have to say. You have to know your audience. So there was definitely a theme that receptivity was part of determining whether or not to broach these conversations. Next, please. Physicians did not think that comfort or their comfort is a barrier to conversations. About half said that they are comfortable discussing anything or almost anything. And so they say things like, nothing phases me, I'm comfortable talking about anything, or I'm comfortable talking about anything, that's my job. Where they did express some hesitation, they said it had to do with lack of training, experience, or new information. So new medications came up, women's health areas came up, mental health, and end-of-life conversations all were things that they were a little less comfortable with. Next, please. But funny, they weren't actually all that comfortable talking about firearms with patients. Many alluded to needing more training, either as part of their initial training or in CMEs. It's not on my radar screen. It's not a typical subject I bring up, were the sorts of things that they said. Next, please. And we didn't ask about gun use or ownership, but physicians volunteered it organically in the conversation, and some volunteered it in the context of it makes them more comfortable discussing firearm safety. So sometimes if I have a chance, since I own a gun, I tell them this is what I do for myself, or they'd say I'm very comfortable in this area. I've had firearms my whole life. Next, please. And non-users also volunteered that because they were less familiar with guns, they were less likely to be comfortable talking or feeling qualified to do so, to discuss safety. Next, please. Interview responses did not vary by policy context. So we had stratified the states into those that do have safe storage requirements when firearms are not in use, and states that do not. And we saw no systematic differences in responses based on those stratifications. But participants did express unprompted awareness of political and social contexts in which they practice. Next, please. And so these quotes indicate, I know the issue with firearms is political, but it's not the way to teach them. It's not about having guns. It should be about, here's how to be safe. One physician said, in some states, it's illegal for doctors to even ask their patients about firearm ownership. Next, please. Now, we asked about specific facilitators in these conversations. Some did mention that billing or a lack of being able to bill was problematic. You can't sit and talk for an hour if you don't get paid. Some talked about some basic things like having a pamphlet to pass along, but most of the interventions that we thought would facilitate the conversations did not really produce much change in physician response. Next, please. So to close out, in terms of aim one for facilitators and barriers, physicians identify a lack of time and screening as barriers to anticipatory guidance, as along with their own perceptions of who is at risk and who would be receptive. There was a need for facilitators for more training, possibly for a billing code as a mechanism to make time for these conversations. And physicians are aware of the social and political context in which they're practicing, and they're considering that when they're thinking about talking to their patients. Next, please. And as this was a seed project, there are a number of directions for future work, including to see if our findings extend to the general physician population more generally, as well as other physician settings and populations. We also are interested in exploring the role of screeners and anticipatory guidance conversations in a PCP setting, and the development of standards-based interventions. Thank you.
Thank you so much, Dr. Janine. We are now going to move to our last presenter, Dr. Siegel.
Thanks, everybody. And I apologize. I was coaching this weekend and I have a bit of laryngitis, so hopefully I'll get through this. I'd also like to add that this study was funded by the NIJ. Next slide, please. So an important background information before we get to the specific aim is that one concept to really understand that there's several studies out there that show that when practitioners do deliver safe storage counseling, parents are more likely to change their storage behaviors, particularly if safe storage devices such as cable locks or lock boxes are distributed. And getting HCPs to deliver counseling messages often depends on their degree of confidence and self-efficacy, which often is related to the training they have had surrounding firearm safety messaging. So this gets to what our specific aim of our study is, to determine the extent to which training pediatric and adolescent healthcare providers on firearm injury prevention counseling improve their knowledge, attitudes, beliefs, confidence, and self-efficacy. Next slide, please. There has been some work done over time in this area, and this is focused mostly on pediatricians and or pediatric residents. Next slide. The one that is most similar to what we have done is a recently published study that looked at a 2-hour multimodal workshop delivered to pediatric residents. And they found that at 6 months post-workshop, healthcare providers were 5 times more likely to counsel patients on firearms, more than 75% of their well child visits. And they also found that there was greater comfort in asking patients about firearms. Next slide. So our study was done as part of a process evaluation done as part of a larger RCT that evaluated the impact of HCPs delivering counseling on access to lethal means. And we did this as a pre, post, and 1-year follow-up design. The intervention was for this particular project was HCP training, which lasted about 90 minutes. We used an adapted counseling on access to lethal means training done between the Harvard Injury Control Research Center, Colorado Department of Public Health, and Children's Hospital. We added an additional section. The CALM training is focused on suicide prevention, but we expanded the knowledge and breadth to include all firearm injury, as well as how to have safe storage discussions in the primary care setting. And we evaluated changes in knowledge, attitudes, and confidence in providing lethal means counseling. Next slide. We did this between 2014 and 2017. It was done in our adolescent medicine clinic, so it had ADOMed specialists and fellows, but also primarily pediatric residents who rotated doing adolescent medicine on a monthly basis, and they received this training at the beginning of their first week of their rotation. Next slide. We had 139 providers participate. 86% completed the baseline survey. 78% were female, 84% white, and as I alluded to, 89% were pediatric residents in training. Next slide. We used two different scales. I'm not going to read through the details, but we'll highlight our findings. Each scale used a 5-point Likert scale between strongly agree and strongly disagree. Next slide. And here is the self-efficacy scale measured in the same way. Next slide. In terms of knowledge, we used 8 questions that we had put together. As an example, we asked providers, what is the leading cause of death for African-American males between the ages of 15 and 24? 63% correctly identified homicide. If you look at the table on the bottom, the pre-test mean for these 8-point questions was 5.4. It improved to 6 post-test, which was statistically significant, which is no surprise when you train anybody. They should hopefully come away with some knowledge, new knowledge. Next slide, please. And then our results of the skills that we had looked at. The first one, the positive attitudes about delivering counseling on firearm safety, had 5 items, had a reliability of 0.66. The pre-test mean and post-test mean, you can see those scores, and we compared those using a t-test. We found that there was a significant difference immediately after taking the training. This did not completely hold up, though, at 1-year follow-up with a p-value of 0.1, but there was some persistence. When we look at the self-efficacy down below, a 4-point scale had strong reliability, and we found significant change from 3.2 to 4.1 pre-test to post-test, which was statistically significant. And that persisted, statistically significant, persisted at 1-year follow-up. Next slide, please. As an example of a few of the specific questions, we found at baseline, 39% of HCPs agreed or strongly agreed that they felt confident in their ability to talk with parents about reducing access to lethal means, which increased to 89% post-training, which was significant. HCPs, 35% of HCPs reported self-efficacy, that they could in fact make a difference when they talk to parents about safe storage. And that increased to 79% post-training. 48% pre-training knew enough about firearms to talk with parents compared to 93% afterwards. And at baseline, only 28% of providers said they screened 50% or more of patients for firearm access. And this increased both the post-training as well as 1-year follow-up to 53%. So I think that was one of our more significant findings. And then 80% of providers felt like at 1-year follow-up, they had had the opportunity to use the concept learned with patients. And this spilled over not just from their adolescent month, which is just a short-lived period of time, but into their regular pediatric training. Next slide. So we found that this training, in fact, does make a difference. And this goes along with the other studies that are out there. And I think it's really important to recognize that, and we talk about doing this a lot, and really the key thing is getting providers engaged in training. The other studies that I had cited, this one shows that if training is in fact delivered, and then that correlates with a change in behavior, despite whatever barriers may be there. So I think that's important to learn. There are new trainings that are out there and available for us to avail ourselves of. Thanks.
Thank you, Dr. Siegel. All right, folks, we have about 15 minutes now to do Q&A. So a huge thank you to our speakers and to their teams, because I know each of you were here on behalf of a large group of researchers. I'm going to invite you all to turn your cameras back on, and I'm going to start asking some questions. And I'm going to summarize some of the questions that came into Q&A. There are a few that I think apply to multiple studies. The first one that I think applies to the last three presentations were really some questions around the content of the interventions and who delivered it. So for example, Sophia, for your intervention, someone asked, was it social workers? Was it research assistants? Can you describe a little bit about kind of who delivered the intervention and whether it was universal or whether it was a more targeted or tailored preventive intervention? Same questions for Eric around kind of the content of the training. What exactly did it consist of? People are kind of looking for things that they can take back to their own either research teams or to their own healthcare facilities. So I'll start with that at the two of you. And then Jennifer, I have a question for you, and Bindi, one for you. So Sophia, you want to lead off and commenting a little bit what your intervention consisted of?
Yeah, sure. So for this particular pilot study, we actually had our research assistants that did the intervention in the ED, and it was a universal approach. And so it wasn't targeted to a particular subpopulation in the ER. We just had them start from one side of the ED, and they just kind of went from one end to the next, and the next research assistant came on and picked up where they left off, so that it was very random, who they would sort of enroll and who they asked. They didn't have a particular sort of, the only criteria was that they had a parent or legal guardian with them. And then the second, and then I think there was a second question in there too.
Those were kind of the two questions, was around who did it and whether it was universal or targeted. And then a related question just for me is, did you tailor the intervention according to what, did your research assistants know whether or not someone disclosed that they had firearm ownership or access? Or was it just the same intervention regardless of what their home situation was?
Yeah, and so it was a self-administered electronic survey, but you would know in the room when you're standing next to them if they're doing the longer part of the survey or not, depending upon how long it takes. But the screen that popped up for the research assistants after the participant completed the survey is that they are prompted to ask if they want to lock or not, if the surveyor had said yes to a gun in the home or a gun being brought in the home. And so interestingly, we actually had people that were still asking for locks. Participants were still asking for locks, even if they didn't answer those questions.
Perhaps because they have friends and family members, right? So many people go to a grandparent's or an uncle's or aunt's house or a friend's house. That's great. Thank you. And Eric, same question to you. Can you provide folks with a little more detail about what exactly the intervention consisted of?
Sure. So the training intervention, as I alluded to, was partly this adapted calm training that I think a lot of people are familiar with, and that is still available for people to participate in and learn from. That we had as a recorded 1 hour or 45 minutes to an hour adaptation that had been done. And so the trainees heard that with the focused message on suicide prevention. I sort of facilitated that and then added that extra didactic discussion about other firearm injury issues such as homicide, et cetera, et cetera. I think that's one of the issues that we have with all of these studies, that it's hard to completely replicate because it's the person who has the passion at whatever institution to do the training. I think the important message, though, is that if people do participate in these trainings, then that is going to change how they practice. At least I'm fairly confident. And there are trainings that are out there now. The AEP has just released one that is helpful, and we're going to be looking at that. So I think to engage in training to improve somebody's confidence and self-efficacy is what needs to be done.
Thank you. I appreciate that. And I think that leads actually really well into the question for Jennifer. There was a question in the Q&A, as well as I think that all of us that are sitting here today, probably throughout the FACS conference, are having these challenges around how do you standardize trainings across different demographic groups, different degrees of comfort with firearms, in different political and geographic areas. And there was one question in particular about how to normalize these discussions. We don't ask physicians to have smoked in order to talk about cigarettes. So would love your thoughts based off of this excellent qualitative work that you did.
Yeah, sure. Thank you for that question. I think one of the findings, which seems so basic, but gave us all a moment, was the role of screening and screeners and EMRs. And there are physicians who talk about things that they're uncomfortable with, end of life care or dementia with older patients, because it comes up on the screening. And so there was a clear need for training. There was some receptivity to the idea that the conversations become easier if you had materials to pass along, right? If you could transfer the information without actually having to necessarily be the conveyor of the information. But much of it starts even before, and it's the decision of what you can cover in a small time frame. And if something raises to the level of necessity based on the EMR or the screener, physicians say they cover it, even if it's a conversation they're less comfortable with. So I think that part of it is just backing up. I mean, we also saw that physicians are using their own internal screening about who they think is at risk, and they're not doing that in a way where they think they're applying bias, but they're looking at me and they're deciding what is most important to talk to me about. And I think that there's all sorts of cultural issues and experiential issues that go along with that. So I would say that screening is a really important way of normalizing and standardizing the inclusion of the conversation.
Thank you. And I think, for many of us, this will echo so much of the work that many of us in injury prevention have been doing for so long, right? Whether it's talking about seatbelts or around partner violence or even around suicide screening, the challenges with getting the fall prevention screening, getting providers to actually ask these questions and feel comfortable that they have the resources available on the other side to deal with a positive answer, which is why I think the pairing of your study with Eric's and Sophia's is just so powerful to think about kind of how do we close that full spectrum. And then, of course, we need to measure our effects, which brings me to Bindi's study. I actually have a question that's not in the Q&A, that's a question of mine. You'll see in the next session, actually, Katie Donnelly is presenting on behalf of a group of us who are doing a different type of deep dive into the accuracy of the medical records and the coding of intentionality. I'm interested in how you trained your reviewers, because one of the things that we have found, and again, this is not unique to firearm injury, it's about kind of many injuries coming through the ED. But one of the things that we find really difficult is that two different people can read the same chart and come away with different senses of whether it was intentional, whether you don't know enough, or whether it was unintentional. And I love this insertion of the bystander category, because it seems like that gets rid of a lot of the confusion. Would love to hear about how you trained the reviewers and whether you measured kappa between them, how you achieved consensus.
Yeah, thank you. No, that is definitely something of concern. I think one of the reviewers was me, and the other two.
That makes it easier.
Yeah, and then the other two are research coordinators who've been doing this for a while. At the beginning, we looked at a bunch of charts together, and so we kind of almost learned together.
Mhm.
And there's no fancy measure of reliability or anything like that, sorry, but basically we had two people doing it, and most of them are pretty straightforward, right? It's like, assault or whatever. Even the accidental unintentional it finds a gun and shoots him or herself is common. It's really these bystander ones that were the most questionable, right? Because it's like, was it a drive-by where they were meaning to shoot, or was it they were just standing in a park or something like that? And we would really have a lot of discussion about each of those cases. We would look in every single note in the chart. The social worker notes are always the best, but the ER notes, the surgery resident notes, the EMS run sheets, sometimes there's police records that were included in here. I didn't present this data today, but we've also been looking at death records from the medical examiner's office. And in the Houston Forensic Office, at least, there's forensic investigators that actually go out and write really, really detailed reports. And including those with the police records, you can get a lot of information about shooting intent. And so I think just because the three of us have been doing this for so long, it's just become a little bit easier. But you're right, when you add more people into the mix, it is harder to produce that reliability. And so I think that just how ICD-10 is so specific for so many things, it's weird that it's not specific for this. And that I think that there's an opportunity to make it more specific so that there's not all of this gray area.
I love it. I mean, I think it just deals with so many of the challenges that so many of us have been having. I know that there's been, and I saw some questions from Eric Fliegler in the chat. There are many of us that have been having offline discussions about, whether or not to even consider intentionality when we're using EHR data, because it's just so rife with inconsistencies. And that was actually his question: is should we just kind of should we even consider it? For the time being, right? So I love the idea of moving forwards. Let's create a new E-code. But given kind of where we're at right now, what would your takeaway be for people that are using EHR or claims data to look at patterns of firearm injury?
I think it's definitely misleading. Especially, and this is pediatric data. I'm also been looking at adult data, and it's way worse because there's no social worker notes.
No.
And all it says is GSW to head, GSW to chest. No one from the ER, the residents, no one writes why. Nobody seems to care why. Or I think
we actually don't. I mean, I'll defend our. As an emergency physician, we don't know why, right?
Well, that's true. That's true. No, that's true. Sorry, I wasn't bashing on anyone.
No, it's okay.
I'm guilty of the same. But even when you go through the chart, like if you look at the discharge summary, there's nothing. Mm-hmm. And I think it's because we are trained especially at busy adult trauma centers, to just deal with the injury, right? But I think that this whole concept of trauma-informed care, as that takes off, adding more social determinants into these things and almost having a drop-down menu where somebody has to go and enter that in when they come in or before they leave, is going to give us some more information around these kinds of things, because I think we're missing an opportunity to intervene at that time.
Thank you. I would agree and love it. So thank you very much. Sophia, one last question. I'm going to come back to you, and then I'll give Jennifer and Eric a chance to weigh in as well. There was a question which I think is really important, right? So you had really impressive results, especially for such a small study. Would love your thoughts onto why your intervention was so successful. And a related question is, are there specific subgroups that you were able to identify who were resistant to the intervention? And I think about this as being similar to our discussions about COVID vaccines, right? As we roll mandates out, we're finding that a significant percentage of our folks that originally said they weren't going to get vaccinated are now showing up, but there's still that small subgroup for whom certain interventions are not sufficient. And so would love your thoughts both on what made yours successful and whether there was resistant subgroups. And knowing that we have about a minute or two left, Eric or Jennifer, if you have thoughts to weigh in on after Sophia's answer, I would welcome them.
Yeah, thank you, Megan. So I think I'd first just preface it with, if you from our data overall, we actually had a pretty good rate of people that were already logging their guns. So like over 80% that had handguns were logging their firearms. And so we're starting with sort of that bar, right? I think, we could potentially postulate as to why our interventions were successful. Part of that may have been related to the education they received. So all of our participants, regardless of whether or not they had a gun, watched an AAP firearm safety video in that initial survey. And those that were given a cable lock actually watched a video that was put out by our Philadelphia Sheriff Department that demonstrated the use of the cable lock, locking up your gun with a cable lock. Okay, now you put in a lockbox or a gun safe. And so like showed sort of that sort of secondary level of protection. And so, I will say that, Eric had asked about like sort of, I guess, the percentiles, like from looking back at our data, about 40% of those that had guns in the home were the ones that took the lock, right? And so then you could argue that 60% of them that already had guns in the home did not take a cable lock. That may have been because they already had the safe storage device at home. I think another thing to really think about is sort of we reminded our participants multiple times. And so like that, does argue as longitudinal follow-up beneficial potentially, like were they not, necessarily locking their gun immediately after the ED, but then when you call them again at 2 months and then you call them again at 6 months, did something finally click? And so I don't know the answer to that. I think that could have potentially been a reason for why. In terms of, what's the best device to offer when looking just at Eric's question overall, I think that, for this particular study, we picked gun locks because we had access to them, the cable locks. And so if you're thinking about a larger project in the ED, thinking about the funding for, a lockbox or a gun safe and whether or not you'd have the capability to do that, although the prices are coming down. I would argue probably the best study would be the one that would give participants options, right? So you want them to be compliant. And so giving them the option of a cable lock or a lockbox and letting them pick, which one suits their gun type the best.
Thank you. And Eric and Jennifer, in our last minute or so, if you have thoughts or reflections on my question to Dr. Chowdhury.
Well, we had actually found a similar thing in our larger study that if people had locking devices at home, we couldn't give them away. They really didn't want them. But we've switched over to doing usual care, and we are giving away a lot of lock boxes and just asking the simple question, do you want to take home a lockbox today? That's not presented as research right now, but it's something that we're finding practically.
I can add in there too. We've done some similar work, and in Texas, at least, most people own their guns for self-protection. So the cable locks, they don't like them because it takes too long to do that. So the biometric fingerprint safes are the best because it's kind of like unlocking your phone. It's really fast. The problem is they're expensive. They're like $200, and I think that we really need to have a push with the producers of those to make more affordable fingerprint access safes.
Yeah, I was going to add in, similar to work that you've done, Megan, cultural sensitivity and understanding the diversity of who gun owners are and why they use guns and the types of guns they use is really important to these conversations. I think our finding about physicians pre-screening internally based on their own perception of who uses and who's at risk indicates that there's a monolithic view of gun ownership and gun use in this country, and physicians are going to have to be able to meet gun owners where they are and understand that's in a wide variety of places.
Thank you. And I think that's a beautiful note to end on for our healthcare symposium, or the healthcare part of the symposium, which is at the end of the day to remember that our job is to reduce the risk of harm while also being respectful of patients. And so I just thank all four of you for these excellent presentations and for your ongoing research. Congratulations as well on your varied sources of funding. It's just so exciting to see all these studies out there that are funded now, and I'm looking forward to years to come.